You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant.
At least one estimate forecasts a shortage of more than 150,000 physicians by 2030 in the United States, with the largest deficit in primary care physicians. Moreover, there already exists a shortage of physicians in rural areas, and that will only become more dire over time. Traditionally, medical schools have been co-developed with academic medical centers that include a hospital system. However, training in the environment doesn't support training for primary care, but rather specialty care. In fact, there is an opinion that academic medical centers are just reinforcing this broken healthcare system. As a consequence, over the last 19 years, beginning with the establishment of the College of Medicine at Florida State University, there has been an increase in the development of freestanding medical schools associated with major research-intensive universities. Now, given the costs of acquiring additional advanced degrees and of building and equipping research facilities, as well as the decline in real dollars of NIH support for research, persons interested in biomedical research face difficult career choices. Yet part of the rationale for developing freestanding medical schools at universities is to drive an increase in research grants from the NIH. However, in the absence of a traditional academic medical center, that pipeline of bench to bedside for translational research makes it more difficult to secure NIH and industry funding. And then there's the question of whether investments in producing more primary care physicians will, in a kind of zero-sum circumstances, reduce financial support for biomedical research outside of that supported by NIH, the pharmaceutical firms, and the foundations. And finally, the shifts in emphasis to patient-centered care, population health, preventative treatment, and community-based delivery of healthcare will likely necessitate change from clinical and laboratory research to analysis of demographic populations known to experience shortages of care who also bear a substantial portion of chronic illnesses. If this sounds complicated, it is. But we have with us today on Innovators a research leader whose professional experience spans the full spectrum of types of medical schools with an eye for promoting and supporting biomedical research. Dr. Geoffrey Joyce is Professor of Biomedical Sciences and Senior Associate Dean for Research and Graduate Programs in the College of Medicine at Florida State University. He earned his doctorate in Physiological Psychology at the University of Florida and completed a postdoctoral fellowship in psychobiology at the University of California at Irvine. Dr. Joyce is a very well-published researcher in the biomedical field, and he's held posts in graduate education and research administration. He has held positions at the University of Pennsylvania, the Sun Health Research Institute, the University of Arizona Phoenix, Arizona State University, Kansas City University, and now Florida State University. Welcome, Dr. Joyce, to Innovators.
It's good to be here. Thank you, Richard.
What is the role of research in the various types of academic medical schools and colleges? And by that, I mean osteopathic, allopathic, and community-focused versions of either osteopathic or allopathic colleges. What is the role of research there?
I believe that the goal is the same, to acquire new knowledge and translate that into improving the lives of the people we serve. The emphasis or focus is certainly different. The partnerships that support the research endeavor differs for these types of medical schools. All medical schools must support basic and applied or translational research, in part because the faculties that are the educators of the medical students need to have as one of their roles to develop new knowledge through research. The translation of the basic science to improved health outcomes remains important. The emphasis, however, can be different without a major clinical enterprise associated with an academic medical center. Most osteopathic colleges of medicine don't have an academic medical center. And of course, community-based college of medicines may not have an academic medical center partner or significant clinical enterprise. Nonetheless, there is a need to develop translational science, even if those pathways to that translation are different. With the clinical enterprise, particularly with a large hospital and healthcare delivery model, there is the opportunity to have strong clinical research expertise and alignment to the basic science with those diseases that need to be addressed in that community, such as heart disease or cancer.
Perfect example.
In medical schools that are focused on training primary physicians, there is the opportunity to focus on community healthcare needs, preventative medicine, research that impacts those communities of most needs, and importantly, collaborate with those communities to develop the translational research that provides the most impact.
I think the key point, I wanted to pick up on one thing you mentioned there. In many ways, the community-centered medical school has, in effect, built into it that opportunity to engage in the kinds of research you're talking about.
Yes, and I think as we discuss this further, it requires a different model. It requires hiring of different kinds of research faculty. I think it requires different platforms to have success. But I think many colleges of medicine and healthcare systems have certainly been moving across a translational spectrum, not to only think in the traditional bench to bedside, i.e. developing a drug to treat a disease. How do we essentially do basic research and applied research with people in our community? How do we collaborate with them to establish, is there needs in mental health? Are there needs in food shortages? Are there needs in response to hurricane disasters? Are there pragmatic clinical trials that really look at how we can improve health in our communities and partner with them to advance the mission? It does, I believe, take a very different thinking and culture from the beginning to develop that.
Well, let me follow up on that. Just how different are the education and training of physicians to undertake research from these types of medical schools?
I think that's an important question. While education and training of medical students in research can be substantially different between medical schools associated with or without an academic medical center, I believe it has much more to do with the mission of the medical school.
Gotcha.
If the primary mission is to train medical students to become primary care physicians, there is less of a need to have an intensive training environment for research. However, the accreditation of all allopathic medical schools emphasizes the need to provide opportunities for research and integrate that into the curriculum. There's also the real fact that even with medical schools that emphasize training for primary care, a substantial number of students will apply for specialty residents that do evaluate their applicants in part on their research experience and expertise. So it is the reality that we have to deliver research education, training, and opportunities as part of the student's medical education. I do think without an academic medical center, the opportunities for mentors with training and clinical research are more difficult to identify the students and requires an intention to develop the infrastructure to support partnerships that provide those research opportunities. It can't. And we have certainly invested in this. And many schools, medical schools, have developed, like us, a 4-year track for students interested in having research training and experience. However, we don't offer an MD, Ph.D. program, which many medical schools within an academic medical center do. Certainly very few osteopathic medical schools offer the DO Ph.D. program. And fewer allopathic medical schools without an academic medical center have such dual degree programs. They are expensive and are based on training of clinical specialists. I do, however, believe, and we are committed to ensuring that our medical students have opportunities for clinical research as well as lab-based research. Much of that research experience and opportunities are what I would term outcomes research,
Ah,
working with medical records in
hmm
order to evaluate outcomes of different interventions, and work now with are developing translational research centers that are in different areas of focus here.
I was struck by the fact that you mentioned that medical students, in many instances, even though they start off thinking primary care, they make decisions to go into a specialization. Do you have a feel for what the proportion of students are who do that?
Well, we think it's about 30% to 40%.
So a
Make
significant
that
number.
switch.
That's a pretty
A
substantial number.
significant number. And I was previously at an osteopathic medical
Hmm
school, and it was roughly the same numbers
Wow.
as well. I think that's probably driven in part by economic
Economics, sure.
decisions. I think it's also the case that interest shift. I mean, our job is to train the best physicians. And I do think we have certainly the opportunity to train the best primary care physicians, and they can also have develop expertise in research. So when they go on to
hmm
their residency programs in primary care, family medicine,
hmm
even obstetrics and
Right.
gynecology, other areas, um, they bring with them the ability to understand new knowledge that's being developed, how that's been developed, and how do you objectively
hmm
evaluate that so
hmm
they can give the best advice to their patients about it. And then, it would be interesting to see if we can reignite the models based on primary care clinical research. I think we've got interesting pathways to go forward.
hmm
I know our faculty are very interested in community-based research, and I'd really like us to develop tools for our medical students about how
hmm
you engage in that, no differently than how we train them to do practice during their clerkship training
hmm
with
hmm
rural care physicians,
hmm
small clinics, not only in hospitals.
It just struck me that back about 50 years ago, there was a little book written by a guy named Jean-Jacques Shriver, and he was talking about events that took place in France in 1968 when the students rose up. And he said at the time he thought there ought to be an addition to the Bill of Rights, and the addition should be the right to contradict oneself and the right to walk away. And I'm sitting here thinking about medical students who say, nope, I'm going to become I'm going to become a primary care physician. Well, you can't stop smart people from changing their minds. And so, as he said, they may contradict themselves by saying, no, now I want to go into a specialization. But in some ways, that's not only not a bad thing, but it also is a way in which you could really get someone who's very, very keen and interested in pursuing research, maybe within the primary care world, but in a specialization. So the number, there's a percentage, when you said 30 to 40%, that's a substantial number. And it may say something about what those first years or two of medical school really do for students when they're exposed to research activities. So it strikes me as it's not a bad thing at all in some ways.
I agree. I do believe, obviously, our what I would call community-based
Mm-hmm,
and college of medicine, or those college of medicines really focus in primary care,
mm-hmm.
still have to keep that as a mission.
Good point.
Our mission is to take students from the Panhandle region and return them as physicians to that.
Mm-hmm.
And I don't want us to get away from that mission,
Understand.
but I do believe we have mission maturation, that
Good point.
what we have to equip them
Mm-hmm.
to do what they can do best within that environment.
That's a beautiful phrase, mission maturation. I'm going to steal that from you.
Thank you.
How do organizations that fund research, NIH, the pharmaceutical companies, and say Robert Wood Johnson foundations and the like, how do they perceive these various types of medical schools, and how do they deal with them in terms of their support?
An important question. I have maintained throughout my my own career in
Mm-hmm.
research, 25 years of that research, and then my research enterprise development subsequently
Mm-hmm.
at a variety of institutions. It's much less about the institution and much more about the quality of the investigator and the quality of the research application that shapes the funding success.
I see what you're saying.
However, I must acknowledge that medical schools that are part of research intensive universities, regardless of that being part of an academic medical center or not,
Mm-hmm.
do have an advantage because the infrastructure to support research
Exactly.
is top notch. And by infrastructure, I mean everything from the laboratories and core facilities to the
Mm-hmm.
services provided by grant support and development. And it is the investment in that infrastructure that is significantly greater in research intensive universities, regardless of whether the medical schools are part of an academic medical center
Mm-hmm.
or not. Many osteopathic medical schools are not part of research intensive institutions, don't have that culture or long-term investment. On the other hand, we are part of a research intensive
Exactly.
university, and it makes a significant difference for us.
Just out of curiosity, we just finished an in-house study of not only the aging workforce in the professoriate, but also in professional staff. And one of the things that we were able to identify is that there's a real concern now that the kinds of people that are needed to support research enterprises, and you know that firsthand, it's not just buildings and equipment, it's people with very special expertise. And the question arises, where do those people come from? And if large numbers of them are heading toward the end of their careers, where are those people going to, how are they going to be replaced? And so it's striking to me that when you talk about the infrastructure that's needed to support research, it goes well beyond bricks and mortar.
I agree. And we've been addressing that for many years, a number of organizations from
Mm-hmm.
Incura to the
Yes.
International Research Administration, NORDUP, that we need to have a pipeline, and this is worldwide, a
Worldwide.
pipeline
Exactly.
of these individuals that in the best of worlds, they would have had their feet both in research and in
Mm-hmm.
administration, but often
Mm-hmm.
that's not the case. I have tried to create a culture here where we continue to train our best people and move them up and give them additional training opportunities. That's really very, very important part of what we need to continue to invest in. I know you had a second question, and that really reflected how we might get different kinds of funding and
Exactly.
from government sources,
Right.
also from pharmaceutical companies and foundations. I do think that NIH funding does differ from these other kinds of support.
Mm-hmm.
And even within the NIH, I think the ability to gain clinical research related grants is more difficult in a medical school without an academic medical
Mm-hmm.
center model. And similarly, pharmaceutical companies that want to support the clinical research enterprise are not going to be attracted to an institution without access to that enterprise. This requires building up a very different pathway through partnerships with hospitals that do support clinical research and or engage in community-based research. The breadth of research supported by the NIH, including health outcomes,
Right.
population research, and patient-centered research, does not require academic medical centers. The ability to attract extramural support whether from the NIH or other institutions, depends on great research questions of high impact, quality grant writing,
Mhm.
cutting edge technology, collaborative teams, and an environment that values research. In fact, I think the environments that support strong interdisciplinary research have a huge advantage in this and
Absolutely.
in the world that we've now broached.
In fact, it's fascinating to me to see that increasingly you score points on NIH proposals in many cases by virtue of the fact that you bring together fields from multiple disciplines. It's been that way in engineering, which strangely enough, at least it was strange to me, the different fields of engineering saw themselves as living in very different worlds. And it's been only in the last 15 years that they've now started to cut across disciplinary lines. And the same thing is happening, it sounds like, in medicine, where if you do not have that kind of interdisciplinary component to your proposal, you're not going to be funded.
I certainly agree, and I think the emphasis now at the NIH
Mm-hmm.
on impact and novelty in approaches supports that in invaluable ways.
It'll be interesting to see whether they'll sustain that. But let me turn to something very specific and very close to you. When we were preparing for this interview, we read the 2018, I believe it was 2018 annual report from the College of Medicine at Florida State, your institution. And we noted what simply jumped off the page, that you have nearly doubled research funding between 2016 and 2018. That I think active research funding topped $100 million. Now, the college itself was founded barely 20 years ago. So how have you and your colleagues increased research funding so rapidly?
Thank you. And I really have to first lay the value in the quality and vision of my predecessor for the position that I currently occupy, Dr. Myra Hurt, who also
Mm-hmm.
led the establishment of this College of Medicine.
Ah,
And she saw the need from the beginning to have an interdisciplinary basic sciences
mhm.
faculty, which is currently our biomedical sciences
Right.
that was equally engaged in teaching and research, ensured that the college had the state of art facilities and laboratories,
Mm-hmm.
the necessary startup packages to initiate their research programs, and co-founded the graduate program. Our commitment to state-of-the-art facilities and cores that now include support for programs in behavioral science and social medicine, autism, geriatrics, and human neuroscience has never wavered. By
Wow.
creating an environment that supports the best research, that feels like a home for our faculty and graduate students, and expects high productivity in research, we've ensured a path to successful extramural funding. I do want to emphasize, however, that under my leadership, we have changed somewhat our strategy in who we're hiring and
Mm-hmm.
how we're doing that.
Mm-hmm.
So we have been investing in the hiring of senior faculty that can now build centers of excellence in translational research in behavioral sciences and mental health, as well as in translational drug discovery. This augments our strengths across other
Mm-hmm.
colleges at Florida State University so that we can develop what I have termed a virtual health science campus. Nursing, social
Mm-hmm.
work, psychology, social sciences and public policy, and communication and information. In fact, we have
Amazing.
recently received the renewal of the Clinical Translational Science Award. There's a partnership between the University of Florida and Florida State University for $29 million, and for which I am the FSU PI. This award is an
Wow.
investment in infrastructure across the university to support translational research that impacts our communities. It is led by a translational science steering committee with a membership from 7 colleges.
So
And much of the translational research that we invest in is in the behavioral sciences, mental health, and
fascinating.
community and rural health research. Areas of considerable strength for our college so that we can build and support core facilities that focus in those areas. It also becomes a win-win for the college and for the university by developing these cross-collaborative our efforts. Our college believes that when we build and support core facilities, such as a magnetic
Hmm.
resonance imaging facility,
Hmm.
it is a resource for the entire university. That allows us to hire the best faculty that want to collaborate with faculty in other colleges at FSU and at the University of Florida. This has allowed us to significantly increase the size of our grants over the last 2 years and be successful at obtaining multi-PI grants. We
Wow.
will continue to invest in our faculty and facilities and broaden the community of collaborators to ensure our growth of research with impact. I think one of the reasons that we were successful in the renewal of the CGSA was that we were able to identify a vision of how we would impact rural health
Hmm.
in our panhandle
Hmm.
community, particularly with a focus in behavioral health and mental health, that we had invested in these centers of excellence in Indigenous health outcomes, translational behavioral science, child and mother's stress during
Hmm.
pregnancy,
Hmm.
other areas that we could coalesce interest and focused activities in, and then use this to develop a pipeline of new investigators that will be
Exactly.
very successful in that. So I think as we go back to our point about what do you invest in over the long time,
Hmm.
you have to have a long-term investment that is successful in bringing these people along, having the core facilities for them, grants developers, grants writers, pre-award and post-award teams, access to
Yes.
pilot and seed grants, develop novel ideas that will move towards funding. And I think that's why we've been able to be that have that kind of the success at FSU.
I think you're being unduly modest because in everything you just commented on, I discern 3 things that I really don't hear very much of. First of all, you've now taken what, for how many years, 35 or 40 years, we've been talking about interprofessional education in the health professions. You're doing it. Number 2, you're not just doing disciplinary work, you're doing interinstitutional work. Your partnership with another Florida university is quite remarkable because typically universities, especially state universities, compete with one another. You're collaborating actively. And last but not least, you talked about the long-term investment. I think you're being unduly modest there too. It takes a long-term vision of where research is going, what can be done, and the kinds of research that can be brought together. So it strikes me that there's some real, to me, exceptions to what is the typical sort of undertaking when somebody wants to really move research up, that you have actually, you and your colleagues there have found those interesting ways of making it happen. And to do so explains to me in a large way why you've been very successful in gaining support for your research.
Well, thank you. I want to really emphasize that success has been a consequence of my colleagues at the other colleges at
Mhm.
FSU, as well as my dean and the vice president of research, as well as the provost, all which over the last couple of years have really focus their investment in faculty hires that are seen as collaborative, interdisciplinary, that investment in core facilities are no longer department focused,
Exactly.
but are across colleges. And I think that makes a difference. I think they, and certainly the colleagues I have that work with me on our clinical translational science award do far more work than the resource dollars that are there, because we see this as a real platform for our next stage of maturation and growth, not only at the College of Medicine, but at Florida State University.
If you could leave something behind for our listeners that you'd want them to know about Florida State and the College of Medicine there, what one or two things would you really want them to grab hold of and hold on to?
I want to focus on that in the frame of, I think, some takeaway points that I think are important. And the first is, you talked about, and I emphasize the value of having a long-term vision. And I want to separate that out from strategies. So for any leaders listening to this discussion, I want to include the value of taking advantage of opportunities if they are within your vision. Strategy is great, but when the right person appears at the right time, find a way to get them on board. Find a way to allow them to lead and develop to their greatest extent, and your investment will be rewarded. That's how I helped ignite our growth with the right person at the right time, who we were able to bring in, do a large investment in to develop a Center for Translational Behavioral Science, but she also brought us incredible success with $13 million in NIH funding, and then another $6 million the next year. And I think it helped cement the culture that we had in mission maturation and ability to be successful in ways that we hadn't been before. I think second, at FSU, as other institutions I've been at, success has been built on developing collaborations across disciplines, departments, colleges, and institutions. To get back to our point, team science and team-based research is the future. And that requires investment in a host of intangibles to develop those teams. Most of the large initiatives to support research occur through those collaborations. They are worth the investment, and that's an investment in time, investment in what I call bridge spanners, people who will actually be able to work across teams, and I hire those people who are, I consider both grant developers, but bridge spanners. I think there's personal investment in doing that. It's not only bringing the right people to the table, but be willing to invest in resources when you see where things are moving towards, and reduce barriers to success and increase the quality and strength of the bridges to get them there. And that creates innovation, that creates, I think, it's excitement around that, and that becomes a strategy to build that longer term vision.
Those are powerful statements. Don't ever waste talent. Always look for opportunities to collaborate, and be aware that innovation can and probably should be one of the fruits of the research.
Yes.
You're doing great work there, sir. I hope we can come back maybe in a year or two and have another conversation. By then, I'll expect you will have doubled funding yet again. I won't hold you to that, but
keep fingers crossed, and continue, and let's all vote for increased funding at the NIH so we can keep our pathways going. Thank you very much.
Thank you very much, Dr. Joyce.
Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.